Very good evening to all of you. And today it's a EDIC Part 1 Mega Mock Test Program. So first of all, I will like to invite all those EDIC preparators, Part 1 preparators, and I'll just give my small brief about myself that I am currently working as Associate Professor and Sub-Dean Examination at AIIMS Patna. I am having few editorial, editor of few of the editorial board members in critical care medicine department, as well as critical care medicine journals. And important thing is that let's come directly to the mega mock test. But before that, I just want to say a few things that today the class is entirely based on not a one-way communication. You can say that it should be a two-way communication. I will put some questions that the questions will be either type K or type A questions. I have put some of the important aspects that what are the why this option is correct, why this option is wrong in a very small tabular form, because the time is very limited. So I have catered around 21 questions. But the topic might be there is a mixed topic. So say I can start or I can start from organ transplant, then I can end to ventilator associated pneumonia, so like that. But one thing that I want to request from you all is that you can chat all your answers in the chat box, and either it would be one option like single best option, or it would be a multiple one like true false like that. And then after the completion of each question, I will deal only few explanations so that you can read it better and you have at least a sensitization that what kind of questions can be asked to related to your EDIC 1. So I'm not going to waste much time. The first question is like this. So the first question is how this question is related to a non-heart beating donors, and you have to mark true and false statement regarding the Maastricht classification. Basically, I want to test about the Maastricht classification that is related to the non-heart beating donors. So the first option is your type 3 classification, that is most commonly used. Second is the time elapsed between the removal of support and mechanical asystole is one of the main determinant of the organ suitability for harvesting. Third option is medically assisted cardiorespiratory arrest in a terminally ill patient is not recognized in majority of the countries, and death by the cardiorespiratory arrest during or after death diagnostic procedure constitutes class 3 classification. And the last option is unsuccessful resuscitation include both out of hospital refractory circulatory arrest and in hospital refractory circulatory arrest. So basically, I want to test the knowledge regarding the Maastricht classification. If you have understand the Maastricht classification, you will straight away answer this question like in the form of true, false, true, false. So any of you wants to attempt this question? If you want to attempt, it's not, you can write anything what you feel that which option is correct and which option is wrong. And here in the chat box, you can write like, at least you can attempt so that you will remember it for a longer period of time, because I am going to tell all those answers as well. I am going to tell all those true and false statement. Anyone from the EDIC delegates wants to answer? Okay, I think the answer has already come. So the first statement is your true, like type 3 classification is most commonly used. And then the second statement is, they talked about the time elapsed. So again, the second statement is also true. The third statement, they talked about that there are various medical assisted cardiorespiratory arrests, especially in terminally ill patient, and it is still not recognized in various countries. The countries like UK and US as well as Spain, these are the few countries where they have recognized. But for better understanding, I will show you this next part. So here the updated Maastricht classification for non-heart beating donors, in which you see that in one part, the type of classification is written. The second part is the description, and second part is the description, and third part is particularities. So I made the MCQ using this table only. And it constitutes, when you will read it in more details, you see that in part 2 or in part 2 classification of Maastricht in heart beating donors, it is basically, it caters out of hospital refractory cardiac arrest as well as in hospital refractory cardiac arrest. Whereas type 3 is basically awaiting death by cardiorespiratory arrest, hospitalized patient with life-threatening conditions. And it is most commonly used. So that's why I asked this question. That is, it is most commonly used, and the time elapsed between the removal of support like inotropic support or any mechanical assist device support and mechanical asystole is the main determinant of organ suitability for harvesting. So this was the option C in option B, in which I have given this option, time elapsed between the removal. And third one was medically assisted care. Why this statement is true? Because you see that because most of the time it is not recognized in the majority of the countries, because it medically assisted cardiorespiratory arrest in a terminally ill patient. So if you'll see the option again, medically assisted cardiorespiratory arrest in terminally ill patient is not recognized in the various countries. But if you'll see that class 1, class 2 is uncommonly used, but it is recognized by countries like Spain and France, whereas these constitute euthanasia and it is type 4. So this can be one of the multiple choice questions for you if the examiner wants to test about your Maastricht classification knowledge on non-heart beating donors. So just thoroughly go through this classification. Every point is important because they might be twist the question, just like I have mixed that choice. See this option: death by the cardiorespiratory arrest during or after brain death diagnostic procedure constitute class 3 classification. No. So class 3 classification is awaiting death by cardiorespiratory arrest, hospitalized patient with life-threatening conditions or who are planned with sustained life treatment, like if you are withholding the standard treatment. So it is like that. Now come to the next question. Again, I want that because the sorry. So before I should go to the next question, I will like that if the candidates like Abhimanyu, Ashok, Hamid, and Madhvi, and Neil, Victor, if anyone who wants to attempt this question, they can attempt. At least you can try. Now, again, a second question related to transplant. They talked about the United Network for Organ Sharing Consensus Committee criteria. Why? Because they made this criteria for predicting the death within 60 minutes of withdrawal of life-sustaining treatment, like WLST treatment. So the question is framed like that. So now the examiner want to test about your knowledge based on your UNOS criteria, and what is the criteria, what is the consensus committee criteria for withholding the life-sustaining treatment, and they put an option except. So whether left or right ventricular assist device is important, whether P of more than equal to 10 or SpO2 of less than 92% is required, whether norepinephrine or phenylephrine of more than equal to 1.2 microgram per kg per minute is required, or dopamine concentration more than 15 microgram per kg body weight per minute is required. Now they want to test whether you know these committee criteria, whether you know the UNOS consensus committee criteria for predicting death within 60 minutes after or within 60 minutes of WLST. So who is going to attempt this question? Anyone in the chat box? At least you write that which option is true, which option you feel that you think that which option is false, so that I think it will be very interesting. Because all these today the mock test is at least one has attempted. No, Abhimanyu, can you write? It's not one option. It's a multiple options. Okay. So right. So if so, you have attempted A, right? It's not true because only one option will be there, right? So we have gone for left or right ventricular assist device. Anyone? Any other candidate who want to attempt some other option? Because only one option is false. The rest all options are true. Abhimanyu has put option A. Anyone who wants to go with A or B or C or D? Because the thing is that if you are not knowing the UNOS criteria or consensus committee criteria for withholding the life-sustaining treatment, it will be difficult. Okay, let's come to the answer. So the answer is C. Why? Because the choice is bit modified. Now you see the criteria. If you'll see the United Network for Organ Sharing Consensus Committee criteria, so this has been these entire document has been taken from the standard textbook as well as standard journal. What is the current existing UNOS criteria? So it says that if your patient is having an apnea, so how will you predict the death within 60 minutes of withdrawal of life-sustaining treatment? If the patient is having an apnea, if the respiratory rate is lesser than 8 or more than 30, if the dopamine concentration requirement of that patient is more than 15 microgram per kg body weight per minute, if the patient is requiring some form of VAD like ventricular assist device, or if the patient is undergoing either a VV or VA ECMO, if the patient is requiring a very high PEEP, if the patient is requiring a FiO2 of 50% or SiO2 of less than 92%, if the patient NORF requirement or phenyl requirement is more than equal to 0.2 microgram per kg body weight per minute, if the patient, in spite adding a pacemaker and it is beating at an unassisted rate of less than 30, or if you are putting this patient for IABP and you are maintaining a ratio of 1:1, or dopamine or dobutamine more than 10 microgram per kg body per minute with a cardiac index of less than equal to 2.2, or if you are maintaining a IBP 1:1 ratio with a CI less than 1.5. So all these are criteria for predicting the death within 60 minutes of withdrawal to life-sustaining treatment. Now you see the option again. So straight away, the left and right ventricular assist device, yes, it is required. It is as per a UNOS consensus committee criteria for predicting death. PEEP is always required. Yes, PEEP, the value should be more than 10, and the NORF or phenylephrine requirement is not more than 1.2. It is only 0.2 microgram per kg body weight per minute. So they can twist like options like that only. So if you know the criteria, you can easily make those options. And that dopamine is more than 50 microgram per kg body weight per minute. So again, you can see that dopamine is more than 15 microgram per kg body weight per minute. So this is UNOS criteria. Now, from the transplant, we are moving towards the determination of brain death. Again, I want to check the knowledge of determining the brain death. What is the prerequisite criteria? So my question is, all of the following are included in the checklist for determination of brain death, except, so I have talked only about the prerequisites, and I have taken all those options as a prerequisite. I'm sure that many of you are going to mark this question because it's only one answer. So many of you can mark these options. The option A is SBP is more than 100. Patient is normothermic or mild hypothermic, where the core body temperature is more than 36 degrees Celsius prior to determining the checklist for brain death. And if you are doing a toxicology screen and you are getting, means if the patient has taken a barbiturate and serum level is less than 20 microgram per liter ml, or if the patient absence of any severe acid base, electrolyte, or endocrine abnormalities. So whether which of the following doesn't fits to the determination of brain death. So who will attempt this question? So what do you think that would be the right answer? Anyone? Okay, Neil has attempted A option. Okay, it's nice that you have attempted at least one, that for determination of brain death criteria, systolic blood pressure. You are thinking like that, whether so SBP should not be more than 100. Okay, fine. Anyone next who wants to answer? Apart from Neil, other one who want to answer? Abhimanyu, Neil, and anyone? You attempt the question, any option you want that you feel based on your older concept of brain death declaration. I don't think so that it's a very tough question, although the option is a bit modified. Yes. But by applying your common sense, okay, Abhimanyu has opted for C. So he's thinking that if you are doing a toxicology screen and if the barbiturate has been given, the serum level should be less than 20 microgram, and he feels that this option is not correct. Okay. Ashok has attempted for C. Very nice. So now it's good that at least 2 or 3 people have attempted. Let's see the answer. So the answer is definitely going to be a C. The reason is this: the checklist for determination of brain death, because every time I was pressing upon the prerequisites, because there are 3 parts: prerequisites as well as the criteria for the various other criteria for declaring brain death, like apnea test is another part, then prerequisite. So I thought that I should keep questions for prerequisite only. So the first option, if the patient is having a central CNS depressant drug effect, whether it is absent, how will you know? If indicated, you do a toxicology screen. If barbiturate is given, the serum levels should be not less than 20. It should be less than 10 microgram per ml. So the serum level should be always less than 10 microgram per ml. But if you must rule out the CNS depression drug effect, whether it should be absent. And the second, there not be any severe acid-based abnormality. You have to maintain, you have to put this prior to doing apnea test. You have to put this patient and control the or manage that severe acid-base balances, manage the severe electrolytes, because these patients are very high sodium. These patients may have very high potassium as well, and these patients may have some hormonal disturbances like cortisol level, like your stress levels. Maybe they will be abnormally very elevated. So it should be made U range. And even the normothermia and mild hypothermia, the systolic blood pressure is to be kept more than 100 millimeter of mercury, and there should be no spontaneous respiration. Apart from cranial nerve examinations, there are various all those reflexes. We will start from head to toe, like your corneal reflex, your pupillary reflex, your cuff reflex, your gag reflex, your, if you'll come further down, your deep tendon reflexes, even your various superficial and deep reflexes, all these reflexes are very, very much absent. So these are the few important points, but the important thing that CNS drug effect should be absent. And how will you know? By detecting the barbiturate. If the patient has received barbiturate, the serum level should be 10 microgram per ml. Now come to the, so that's why I modified those options. Systolic, it's right. Normothermia or mild hypothermia, again, it's right. And okay. So if I highlight this, so again, this is right. And this is again right. Here, the issue is about the 20 micrograms. So again, if you think that if it is again 20 and absent, there should be absence of all severe acid-base abnormalities and electrolyte abnormalities. Okay. Now, let's go to the next question. Now, again, a very important, just you think that the examiner wants to test the concept of your ICU-AW, that is ICU-associated weakness. Now, again, the concept is, I want to test one answer, which is the answer is most wrong. Yeah, most inappropriate answer. Now, the question is, it constitutes the 3 entities like CIP, critical illness polyneuropathy, like critical illness myopathy, and critical illness neuromyopathy, like CIPMN, or combination of both CIP as well as CIM. Although it's a very big chapter, but I have given few options where we can discuss few things more. Okay, I have got a answer, I think. Okay, Bhaskara has option has ticked option D. Okay, let's go. Now the second option is, these conditions occur in 50 to 70% of the patient, meeting the diagnostic criteria for SIRS, as well as in patient who are immobilized on mechanical ventilator for more than 1 week. So these must be one of the criteria, whether this criteria is there or not. If a patient requiring a mechanical ventilation for more than 1 week, that you can tell a definition like ICU-associated weakness. Second, if the patient is receiving a very high dose corticosteroids, whether it has some indirect effect, physiological effect on the muscle fiber, because of indirect physiological effect on the muscle fiber, typical myopathy with loss of thick filament protein is there. And last option, HIV or human immunodeficiency virus associated myopathy is associated with weaknesses in intensive care unit patients. So now, how many of you wants to attempt this question? Bhaskara has attempt. Anyone more? I want 2 more people to attend so that we can have a discussion. Okay, Abhiman has marked B. Good. Neil has marked D. Okay, so Neil is going with HIV also, HIV along with this. Ashok marked D. Okay, very nice. So I'm getting a mixed answers, options. So okay, so it's not that straight. Okay, but it's good that you all guys are attempting. Here the answer is C. Now, if you will see very means closely, the option is just slightly twisted. The high dose corticosteroid have an indirect physiological effect. No, it has a direct physiological effect. How will you know? A few things, because this has been taken from the 𝒉𝒂𝒂𝒏. Okay, so entire word has been taken from the 𝒉𝒂𝒂𝒏 only, because now the questions will be from 𝒉𝒂𝒂𝒏 only. So here, now see how these ICU-associated weakness. Now, this term describe the weakness developed in critically ill patient after the onset of illness and in the absence of some unidentifiable cause. I will talk about the unidentifiable cause later on, but before that, you understand these ICU have 3 clinical entities: CIP, CIM, as well as critical illness neuromyopathy. That is, and these conditions occur in 50 to 70% of the patient. If you combine these 3 conditions, it is occur in 50 to 70% of the patient. And why 50 to 70% of the patient meeting the diagnostic criteria for SARS, as well as in patients who are mobilized, who are not mobilized, on immobilized and on mechanical ventilator for more than 1 week. Say, if they give an option for more than 3 days, so it is never a ICU-associated weakness. If they give an option for more than 5 days, it should be a never. If they give an option for more than 7 days, then it would be fitting a criteria for mechanical ventilation. Now, they manifest as limb weakness, difficulty in weaning from the mechanical ventilator. Now, the next option is, sorry, I mark all those things, but okay. Now, okay. Okay, so let's go that here there is evidence suggesting that these patients, if received a high dose of corticosteroid, they have a direct physiological effect, not indirect physiological effect on the muscle fiber, resulting in what? Resulting in typical myopathy and loss of thick filament proteins. Even these patients have atrophy and weakness that are observed primarily in the muscle trunk and extremities, leading to functional denervation of muscles if these patients are receiving NMBS in combination with corticosteroid therapies. So this is one of the plausible explanation. And the other explanation is, what are the various causes of weakness in ICU? So there are a long list. I have not tested. I doesn't want to test about Eaton-Lambert, about the myasthenia gravis, about the GBS, about the spinal cord injury, because I was very, very much sure that if I put this option, definitely you are going to mark these questions, because these are very pertinent cause of causing weakness in the ICU. That's why I have given this option, HIV associated or HIV virus myopathy. Now you see the options. The human immunodeficiency virus-related myopathy is associated with weakness in the intensive care unit patient. So here, one of the viral disease like HIV is associated with myopathy, and these can be one of the cause for ICU-associated weakness.